Hello, everybody, to this exciting meeting. It's UGW, but it's not UGW as you know. It's a virtual UEG week because we have the Corona crisis, as you know. Now I would like to introduce you this on-demand industry symposium, which is sponsored by Pentax Medical. My name is Ralf Kiesslich from Germany, and I'm thrilled to have excellent speakers. And we have three topics which we would like to talk with you. The first is the disruptive new technology of artificial intelligence. It's the next level of intelligence to fight colorectal cancer. And it's my pleasure to have Peter Siersema from the Netherlands and Timo Rath on board from Germany. Then we're coming to the question how to approach the difficult lesions. Should we do ESD or EMR? And what kind of new establishing techniques we will have in our hands. And there's Arjun Koch from the Netherlands and Pradeep Bhandari from the United Kingdom, and they will show you some videos and discuss how to approach those lesions. And then we're coming to interventional endoscopic ultrasound procedures. And there we have three really striking questions: how to drain lesions, fluid collections after pancreatitis, how to approach the biliary tree, and how to do all these advanced techniques. And there it's really my pleasure to have Alberto Larghi from Italy and Schalk van der Merwe from Belgium. Every speaker will announce his disclosure of conflict of interest. I have none because I'm working in a private hospital chain by Helios, so I have nothing to declare, but I'm very curious, what is your disclosure, Peter? And I would like to hand over Peter because we're coming now to the next level of intelligence to fight colorectal cancer. Peter?
Thank you very much, Ralf, for this, I think, fantastic introduction. In this first part of this symposium, we will speak about a very exciting development in the field of endoscopy. And it means that we have now a system available which is called computer-aided system that can be used for detecting lesions in the GI tract, and especially during colonoscopy. And I'm very excited to be part of this group because I think this is really something that is of high interest to all of us, being all endoscopists. And one of the persons who has been very productive in this field is Professor Timo Rath. Professor Timo Rath is Professor of Endoscopy in the Ludwig Demmlich Endoscopy Center of Excellence in the University Hospital Erlangen. And he will share with us his first experience, and that goes actually from development to first clinical experience with discovery detection system.
Thank you very much, Peter and Ralf, for the kind introduction. And before we discuss how the system was developed and the first clinical experience with this system is, this is my conflict of interest. And I'm sure you all have heard a lot about artificial intelligence. Basically, artificial intelligence is everywhere now when we talk about lower GI endoscopy. And as you're well aware, one of the biggest challenges is to generate the artificial intelligence system and to collect a sufficient amount of images. And to train this system, which is called Discovery, we collected more than 115,000 colonoscopy images from nearly 300 patients during routine colonoscopy. And afterwards, and this is also a labor-intense part, in every single image, clearly those polyps that are there have to be manually annotated. We did this by involving 5 experts in the field, and those manually annotated images were then treated as the gold standard and used to generate the DCNN. So this is our training set. And from there on, we went into a first X-Vivo pilot study, meaning that we challenged the system with a variety of images or video frames and assessed the diagnostic performance. And the characteristic of those videos or images you see here in the right-hand table. So we used more than 15,000 video frames as a test set. And as you can see, it was very balanced between polyp-containing frames and non-polyp-containing frames. And also we are thinking we don't want to focus so much on the obvious lesions, not so much on big pedunculated polyps, but have a rather challenging test set. And that you can see here. So half of the polyps were of flat morphology, Paris 2A, 2B, with a mean size of 6 millimeters. So really small and flat lesions were present in this data set. And when we analyzed the X-Vivo performance, we saw that the system has a high sensitivity of 90% for localization and detection of the polyps. And when I say localization, I mean that the discovery system correctly localized the polyp within the frame by putting a bounding box at the borders of the polyps. And this sensitivity was against the specificity of 80%. And when we calculated diagnostic performance, we obtained an area under the curve of 92%. So having said this, we saw that this X-Vivo a quite sensitive system with high specificity at the same time. And from there on, the most obvious thing is that we went into first in vivo trial. And what we see here is a very first pilot study where we included patients that presented to our department for screening or surveillance colonoscopy. And here we did a tandem approach. First, we inspected every colonic segment, meaning cecum ascending colon, transverse colon, and descending and sigmoid with HD white light. And then followed by a second inspection of every segment now with the use of Discovery AI. And then we compared what we see additionally with Discovery. And what you see here are the baseline characteristics. And I just want to point out one thing. Here, Boston bowel preparation, although the mean was 5.7, we had a range with 3 at the lower end. So this was really, these were patients presenting for routine endoscopy in a daily scenario. So bowel preparation was less than optimal in our cohort. And as you can see also by the age, it was a typical screening cohort. Now, what you can see here when comparing the withdrawal times during first inspection without Discovery and then second inspection with Discovery, they're virtually identical. And what did we find? So after first inspection, we had a total number of polyps in all those patients of 28. And that was increased after second inspection, now with Discovery this time, by 86% to a total number of 52 polyps, meaning that this translates into an increase of polyp detection rate from 36% baseline to 50% with the use of Discovery. Something very similar for adenomas, total number of adenomas after first inspection, HD white light only 18, and increase after second inspection, now this time with Discovery, by 61% to a total number of adenomas found of 29. So 11 additional adenomas as an absolute number were found with Discovery. And this translates into an increase of adenoma detection rate from 25% baseline to 33%. What were these adenomas that we additionally found? And that you can see here on the right-hand table. So 50%, more than 50% of the lesions that we additionally found with Discovery were of small or diminutive size. There were more than 50% were located in cecum ascending colon, so right-sided lesions. And as you can see here, and this is the most remarkable result, at least to me, we had 3 SSAs that were additionally detected with Discovery, but not with HD white light during the first inspection. And this corresponds also to the morphology here. More than 50% of the additionally found lesions were indeed of flat morphology, Paris 2A to B. And here you see typical examples on how Discovery detects in vivo. And the very first video that you see here is an easy example. Here we have an 1S lesion that is robustly detected by the system. But this is a lesion, then again, that probably no one would have missed. The second example that you see here is a little bit more challenging. Here on the upper part of the image, you see a flat lesion 2A, 2S, 6, 7 millimeters. And if you look carefully, this has a type 2 open pit pattern. And this was an SSA that was detected by the system. And the third video is the most remarkable video, at least to me, because there's a lot of contamination left. And as you can see here, even in between this contamination, a polyp is picked up reliably by the system, while all the other fecal residues are not detected. Of course, this is not the end. There's more clinical evidence to come. We're just about to start a randomized multi-center controlled trial under the lead of Peter Siersema. We will have 10 centers involved globally. And of course, we'll assess as a main study parameter the ADR between those two study arms, colonoscopy with AI discovery or without. But needless to say, we'll also look at other parameters of quality during screening surveillance colonoscopy, such as polyp detection, mean number of adenomas and polyps per patient. So it's not the end. Stay tuned for further results. And with this, thank you.
Thank you very much, Timo, for this very excellent presentation showing what we can expect in the near future when we are using discovery for colonoscopy.
Yes, I really would like to echo Peter's saying that this was a very interesting presentation, and discovery will be for sure a disruptive technology. Peter, as you are now the principal investigator of this big upcoming trial, I would like to start with the first question. How much time does it take to become familiar with the Pentax discovery system? How is this set in the study? Are there 10 examinations, 20, 50? How do you have this defined?
Well, thank you, Ralf. That's indeed a very important question, because as you can imagine, if you start right away including patients in the study, that will definitely will not lead to the results that you like to have. So it's our advice to perform at least 5 studies before you start including patients in the trial. And that's also my personal experience. So after 5 procedures, having used the discovery, well, you have the feeling that you're familiar with it and that you actually can do and see what you like to see.
Yeah, I think it's an easy system. You can learn it quickly, but you need at least 5 examinations. And Timo, I was impressed about your presentation. It seems, from my view, that the discovery was highly affected in the right side of the colon, and you discussed these serrated lesions. So how many lesions you were surprised that the system found it and you had problems with your naked eye to identify those lesions?
Yeah, that's exactly true. As far as we can tell from these really pilot data, it's especially good for detecting flat lesions in the right colon. And I think there are 2 things to consider. We learned last year from a large meta-analysis published in Gastroenterology that misrates, adenoma misrates, reach up to 26%. And those lesions with highest misrates were lesions in the right-sided colon with advanced histology, flat lesions, and serrated polyps. And this was a study that included more than 15,000 tandem colonoscopies. So it's really rock solid evidence showing that the association is there between misrates, flat morphology, small lesions, proximal lesions. Now, with discovery in this very first pilot trial, we see that exactly those lesions are very well detected, maybe better than with the human eye. Small or diminutive lesions, right-sided colon, flat lesions to A to B, and among them were 2 SSA. So to me, it's very well possible that a discovery closes the loop here between misrates that are associated with flat morphology, small lesions, a proximal location, and very sensitive detection with discovery. So we'll see from also further trials whether this really closes the loop here and fills this so far unmet clinical need. If that holds true, it's really the missing piece in the puzzle, if you wish.
Well, I fully agree, because I think that is really one of the beauties of this system, that it may help you also to see those lesions that are now probably responsible for quite a few of these missed cancers that we still see in daily clinical practice. So I have actually another question for you, Timo. What is the risk of blind spots when a discovery system is used, and how can you prevent this?
Yeah, that's a great question. Well, of course, discovery can only detect what is inside the image or what is displayed on the screen. And blind spots are commonly associated with suboptimal or insufficient exposure of the mucosa. Think about polyps behind the folds or polyps within the flexures, where the scope tends to slip when we withdraw. So these are typically blind spots. And having said this, I think that we as endoscopists need to make sure that we minimize blind spots and make serious efforts to enhance mucosal exposure. And the last decade brought distal attachment devices, endo rings, endo cuff, whatever they are called. And here it's been shown across studies that when you use those devices, you increase your ADR, especially endoscopists with a rather low ADR. And the same principle holds true for a balloon-assisted colonoscopy with GI. That was the result last year in a large, more than 1,000 patients randomized to 2 arms, either standard HD white light colonoscopy or balloon-assisted colonoscopy with the GI. And the principle is here that we have a balloon at the distal part of the endoscope that we inflate during withdrawal. And by doing that, we not only flatten folds, but we also have a very controlled withdrawal where we can carefully inspect the mucosa and achieve maximum exposure. So I assume or expect studies to come that combine those two devices. Devices for maximizing mucosal exposure, such as GI, in combination with artificial intelligence to really fill in this so far unmet need.
Yeah, Timo, and also another question, are you overwhelmed by the acoustic information and also the colored square which is dancing over your endoscopic screen, and how often are you seeing then false positive results? What is your experience?
Yeah, so false positive is an important aspect. In those patients that from which I showed data here, 50% of the patients, so 18 patients, had at least one false positive hit. The mean number of false positives per patient was 1.5. So to me, this is really an acceptable rate. But I don't think that false positives are necessarily bad. We all know that during the day, we develop some degree of fatigue. And also, in the majority of departments, there's always another stimulus to the endoscopist. Think about emergencies coming in, someone entering the colonoscopy suite asking you, can we scope this patient also? And so there are a lot of moments where the endoscopist is distracted for the one or other reason. And then also, if you then have an acoustic alert, that helps you, at least in my experience over the last 9 months, to maintain focus on the procedure. And also, I think we'll see that from other studies, false positives might also have an educational or training effect, especially on young endoscopists. If they are in the situation that they need to assess a lesion after it's been detected and to make a decision whether it's a false positive or a true positive, this might have some educational benefit, especially for young endoscopists.
Well, I think for now we have discussed the most important topics that are related to artificial intelligence and what we can expect in the near future. I'd like to thank Timo and also Ralf, you of course, for taking part in the discussion. And having said this, I'd like to thank you for you as watcher of this. I'd like to thank you for your attention.
So after this very nice topic about artificial intelligence, we move on to our next subject, which is on ESD and EMR and New Establishing Techniques. Now, my colleague Pradeep Bhandari will talk about EMR and New Establishing Techniques. And I will first show you a few cases doing ESD. First case will be in the esophagus, and there will be one in the rectum. I'll show you my disclosures here and then quickly move on to the next slide. So I'll show you a video of a circumferential lesion in the esophagus, in a squamous cell cancer. And now to understand what we're doing there in this circular lesion, I have this cartoon drawn out for you. Here you see a lesion with markings around, and I started, the red dots is my circumferential incision line. Now, for a complete circumferential lesion, I would not make this lateral incisions, of course, but I would make a distal circumferential incision first, and then my proximal incision, which I usually call a C-shaped incision, because that opens like a smiley and gives you good access to your submucosal tunnel. Now, in the next slide, you will see that I have left these two tissue bridges, which is very important for orientation, because before you know it, you are halfway during your dissection, and you have a lot of tissue hanging in the lumen, making visibility and orientation very poor. So then you tunnel underneath. This is what I show you here in the light blue. And if you have tunneled all the way through and connected your tunnels, you can cut the tissue bridges at the final part of the procedure and take out the whole specimen in one. Now, it's hard to show you this in a 2-minute video, but I'm going to try anyway. So I marked both distal and proximal circumferential incision line, and here I started at the distal part. We're using a splash M knife, as you can see here. So we made a first cut, and then we can use the knife as a hybrid knife for injection in the submucosal space and circumferential cutting, which is now almost done. Here, our distal circumferential cut. When we complete that, we move to the proximal part, which will probably be here already. And then we move into this tunnel. It has to be brought to you in a 2-minute video, so sorry for this very quick video. Here we move into the tunnel, stepwise injecting and cutting, and finally we have a tunnel all the way through this lesion, which is about 5 or 6 centimeters in length. We make a second tunnel on the opposite side of the tubular esophagus, and again we tunnel our way completely towards the other side. And this is what you see here. So we perforate back to the normal esophageal lumen, and now we have 2 tunnels, as you can see here. So the specimen is now suspended with 2 tissue bridges. We try to cut the bridges as far as possible before we cut the most proximal part of it, and then we can take out the whole lesion. I hope you're still with me. Now we move to the proximal parts and we take out the last pieces. As you can understand, this is not done in 2 minutes, but it might take an hour or 2 for sure. So it's very precise work and you need to make time for this. And then have the whole lesion removed. Now you can see the bare esophagus. The complete circumferential mucosa is gone. We retrieve that, of course, and we pin it down. It's still circular, so we have to pin it down with probably with the paraffin inside. And this is your scar. With the help of a few dilations and some topical budesonide, this all went really well. And it was a curative case. Now, I quickly move on to a case in the rectum. This is an ESD, or actually combined with an intermuscular dissection of an early rectal cancer. As you can see, and we assessed, this was, well, early, but maybe not that early. I see the video is not, it should start automatically, but if it's not, we will move to the next one. And here you can see we make a start. We did a circumferential incision, at least in part. We left a few tissue bridges on the lateral sides. And now we start cutting the circular muscle bundles. And you might wonder, what are we going to do there? Are we going to perforate? Now the intention is to cut only the circular muscle bundles and leave the longitudinal muscle bundles intact. And we do this because we anticipated in this case that there might be deep submucosal invasion, or maybe even shallow muscle invasion. Here in the next slide, you see that we slowly progress, and you see the longitudinal muscle bundles really nicely here. This looks a lot similar to a TAMIS procedure, the way the surgeons do that, and we can do that just as easy by endoscopy. Now, slowly progressing, peeling off the circular muscle bundles from the longitudinal bundles, and we will have one big resection along with muscle. So for proper histological assessment, and you'll see in the end, you'll see the end result. This video is almost done. And this is a picture of the final result. You see these longitudinal muscle bundles, and we resected the whole lesion en bloc. Histology in this case showed an SM2 invasion with moderate differentiation, no lymphovascular invasion, and low tumor budding in a radical resection. So in my opinion, this was a curative resection. I think a lot of colleagues would agree. In the past, this might have been considered deep submucosal invasion and a case for surgery, but there are more and more data coming that we could definitely treat this by endoscopic means. So this was my final slide, showing you, I think, two interesting cases where ESD is really needed to take care of these lesions. And now I gladly hand over the presentation to my colleague Pradeep Bhandari, showing you that there are also indications for EMR and other exciting techniques. Pradeep.
Hi, my name is Pradeep Bhandari. I'm a consultant gastroenterologist from Portsmouth, UK. And you heard the talk by Arjun on ESD for colonic neoplasia, as well as for upper GI. I'll focus mostly on colonic because we do a lot of colonic resection, and show you a couple of cases to say that EMR and a modified EMR called knife-assisted resection or CAR also has an important place in the resection of colonic neoplasia. So let's move on. These are my conflicts. This is a patient with a cecal polyp. You can see it's a large LST in the cecum, almost going into the ileocecal valve. So we do this usual assessment, no risk of cancer in this. Retroflexion in the cecum, first injection into the terminal ileum, pushes the polyp out, and then keep the scope retroflexed, and we take a bite with the snare. And after the second bite, you see a little bit of bleeding there. Now we in the cecum, we got to be very careful. The only device we have is, at that point, its old video is called monopolar hemostatic forceps. We use that to stop the bleeding. Then with the straight scope, it's a straightforward EMR, everything resected. You see 3 months later, no recurrence. So the diagnosis was low-grade dysplasia. And I think in this kind of polyp, the role of ESD would be controversial. It will be very tricky. The risk will be high. And if we are confident with our optical diagnosis, there's no need to put this patient through ESD, or as a matter of fact, some centers would consider doing right hemicolectomy because IC valve was involved. Again, you can see how effective EMR can be to avoid a drastic surgery in this patient. This is another example, another right-sided polyp. So it's another LSTG smooth type, but one of the biopsies in this case showed high-grade dysplasia. So here we wanted to be very careful. I'm using a special knife called K-snare, which is a snare, but when you pull the snare in, the tip becomes the knife. You can see there, as I pull the snare in, the tip acts as a knife. We got nice injection. We use it as a ESD knife to make a mucosal incision. I got a brisk bleed there. I just use soft coagulation, 80 watts, and the tip of the K-snare, and that stops the bleeding. And then I carry on to complete my circumferential mucosal incision all the way around it. and then perform a little bit of dissection, because the aim here was to achieve en bloc excision. So here, once we got all the dissection, I can capture the entire lesion in the snare. So just open up, capture it in the snare and resect. So it's a very efficient device, allows you to cut as well as to use it as a snare and resect. So it cuts down the procedure time a lot and still achieve the en bloc excision that we wanted in this case. So it makes it quite an efficient procedure. This is the video showing you how we can reduce our recurrence rate, because the big criticism of EMR is that it has a very high recurrence rate of up to about 20%. Data from Sydney, Michael Burke's group has shown that if you use soft tip coagulation after doing EMR like this, then you can reduce your recurrence rate from 20% down to 5.8%. This only takes about 5 to 10 minutes after a large EMR, and that can achieve very low recurrence rate. So it's quite an effective technique, and I think we're going to see this a lot more going forward for those of us who do a lot of EMR. However, with the CAR, the knife-assisted resection, you don't need to do that because we're cutting in the normal mucosa. And you can avoid this soft tip coagulation if you do knife-assisted resection with a case snare, as I showed you earlier. Now, this is another example, a patient who's had previous stents and now has got a recurrence in the rectum on a scarred area. So it's a very scarred polyp, you can see. So we use the knife, done a dissection and incision all the way around it. Once we've done that, we use the case snare again and capture the entire polyp and resect it in one piece. You can see how scarred it is, but we still managed to get a single piece resection. The other example would have been what Arjun showed you, where you do very careful dissection and take the muscle with it. Here you can see that you can avoid that and use this to resect it without taking the muscle with it. Finally, this is a large polyp in sigmoid colon, very difficult to get close to it. In the straight scope, it's almost impossible to see this polyp properly. So we had to do it in this fashion in a retroflex. I'm using the case snare again. It's very difficult for me to get good access. So you can see here, I've deflated the colon completely and I've immersed this polyp under saline. So it's completely immersed under saline, and I'm cutting with the tip of the case snare using as a knife around it and making a small, there's a large vessel as you saw there. I'm using this bipolar hemostatic forceps from Pentex to coagulate that vessel before I cut it. And then we can carry on again underwater, under saline. Now I've hit another vessel. You can see it's bleeding. With water, you can see the bleeding point. I'm using the bipolar forceps again to grasp the bleeding point and coagulate it. It stopped the bleeding. And now we have just turned around, gone on the other side, completed the incision and made a little bit more submucosal dissection underwater. I've dissected enough now. So I'm going to open up the snare and capture this in the snare and take it off in an en bloc fashion. Depending on the skills, we can carry on and dissect the whole thing with this knife. Or if we are running short of time, this allows us to use the snare and cut down some of the time. So again, here we can see we have achieved an en bloc excision, completely excised with all these vessels being coagulated and an en bloc excision achieved. So I think this device gives us the option to continue performing full ESD if you have the skills and the time and a clinical necessity to do so. But if you don't have the time or the skills or no clinical need to carry on doing the full ESD, you can easily convert it into knife-assisted resection with the case snare and resect it very efficiently and quickly and achieve the same aim. So there I finish and will be happy to take questions after this.
Thank you to both of you. These were really exciting talks and interesting new technologies. And Arjun, you really thrilled me because that was a completely new technique to cut the circle muscle. I realized that you used the Splash M knife from Pentax Medical during the procedure. What is your experience and the advantages of this kind of newer knife which is available?
Well, what I really like about the knife is it has this dual function. So you can inject and cut with it at the same time. That shortens your procedure time, and it makes you don't have to replace your knife with an injection needle all the time. And if you have to do that, of course, then you try to cut as long as you can, might be even become a little bit dangerous. But here you can elevate your lesion at any time, whenever you like. So it's very safe, it makes it faster, and that's what I like about it. It has a really nice small tip for very precise cutting.
Pradeep, you made a very elegant presentation as always and showed impressive results with your technique. You had two new devices. One was the K-snare. There was obvious advantages because you could use it as a snare and as a knife. But what about the bipolar coagulation? I think that's a new possibility. You showed the old technique in your very first video, and now it's a new technique. What are your advantages and how you use it, this new technique from Pentax?
So that's a very important point. I think the availability of a bipolar hemostatic forceps from Pentax has added a new layer of safety to endoscopic resection. In my first video, I showed you that in the cecal polyp, we got bleeding in the base of EMR, and I was really scared using a monopolar forceps because the risk of perforation remains very high in such situation. But now we have a bipolar forceps, which reduces the risk of perforation. So it gives us added confidence in treating these bleeding points on top of the muscle. The only worry to start with about bipolar was, will it work, will it not work? But we have plenty of experience now to show that it's really effective, it's very safe, and it gives us that added confidence in dealing with these really dangerous bleedings in complex resection. So I think the safety of endoscopic resection has suddenly been improved even more with the availability of this forceps.
All right, thank you again, both for you for these excellent presentations. And now we move forward to our last topic.
Hello, everybody. My name is Alberto Larghi. I work in Rome. This is going to be a session on interventional US, and it's going to be an interactive section with my friend Schalk van der Melde from Leuven in Belgium. So these are all our conflict of interest. So we're going to talk about the open question on interventional US. As you know, interventional US is a growing field of interest with the procedures that are established and procedures that are taking place to other procedures surgically or endoscopically. And this is why Pentax developed a new series of linear therapeutic endoscope that is the EG38J10 UT that has changed completely from the previous one because it's actually much more maneuverable from the previous one. I'm not from Pentax before, so I worked for 15 years in Olympus, and I love the maneuverability, but I was always in the ultrasound the ultrasound image of the Pentax scope, and so Pentax reduced the tip of the scope, but the image is actually better, and finally developed a 4 millimeter working channel that can be very useful for certain interventional US procedures. So the procedure we're going to talk today are pancreatic fluid collection, and the key question are standard of care but still open question. biliary drainage, and this is a very sexy question, that is, will US replace ERCP for unresectable distal malignant biliary obstruction and gallbladder drainage if we are reach the point where for high-risk patients with acute cholecystitis, US drainage is better than percutaneous drainage. So regarding pancreatic fluid collection, there are still open questions. We know that pancreatic fluid US drainage is better than surgical drainage and interventional radiological drainage, both for pseudocyst and one, but there are still open questions. In fact, we have a question about the use of plastic or lamps that are luminal opposing metal stents for both pseudocyst and one. For regarding direct endoscopic necrosectomy, when do it and how to do it, and at the end of the procedure, if a lens has been placed, if a double pigtail stent should be placed through it. So I will try to share with the Schalk with this question while we are gonna see a movie about a drainage of a large one, a large collection. You can see the necrotic tissue. This procedure is done with the hot axios, so a lens, a lumen opposing metal stent. The procedure is all done under ultrasound guidance without endoscopic or fluoroscopic guidance. Then when you place the stent, you can decide to go in directly and perform direct necrosectomy. And this is usually depends on the amount of tissue and the clinical condition of the patient. So you can dilate the inner part of the stent, then go inside. This is a video of 4 or 5 years ago, so we still didn't have any accessory dedicated to necrosectomy. So we use accessory from ERCP. This is a basket, a Dormia basket, and then you basically go in and out and clean all the material inside. So this is almost clean. You can use hydrogen peroxides to kind of melt the necrotic material and easily to make it easy a cleaning. So what do you think about Schalk? What do you think about using plastic or metal stent for pseudocyst and or one?
Yes, thank you, Alberto. I think that's an excellent video showing the principle of what we're trying to achieve, and that is to remove necrosis. And as you said, there are a few very important questions that remain unanswered. And one of the questions indeed is the question of the use of plastic versus lumen opposing stents. And I think that if you look at the recent study from the group of Robert Halls from Florida, I think what came out of that study was that there was absolutely no difference when they compared the two techniques, placing plastic or metal stents. But if you look very carefully in the study, quite a few of these patients in both arms required additional interventions. So it's not just a question of that we can interpret the data as the use of metal versus plastic stents. Many of those patients, up to a third, required additional endoscopic or percutaneous interventions. So the take-home message there was that, for me, was that there is no difference, but I think it also depends quite heavily on what type of collection you are draining. And we have to define within the world of necrosis the degree of necrosis. So in patients with very limited necrosis, I'm pretty sure that placement of a plastic stent will be as good. If the degree of necrosis increases and you must move towards combining the initial drainage with necrosectomy, there, of course, you need access to the collection. But what are your thoughts? What have you taken away from those publications?
I agree with you. There's at least 5 meta-analyses that basically show that lamps are better for both pseudocyst and one, but are basically based on all retrospective studies. So there are a lot of bias. Now there is a study from Spain, ongoing study. Is a multi-center study where they will compare plastic versus metal stent in one. And I agree with you. I think the degree of the necrotic content can drive your decision. Even though, for example, I just finished writing a paper on intra-observer agreement based on US videos on pseudocyst and one, and the agreement on the degree of necrotic content is really poor. So there's a lot of there's a need. So the best test to address the quantity of necrotic content is MRI, but MRI is usually not done because the patient arrives with a CT, and people tell you, why do you need an MRI for? So
what you are saying is we are comparing apples to pears rather than apples to apples. Yeah.
Exactly, I agree. And you know, for example, for a necrosectomy, I don't know if you. What is your feeling about performing? When do you perform? And if you perform, if you feel that the necrosectomy is needed, you perform at the first, at the time of drainage, or you leave a few days, 3 days, 4 days for the stents to stabilize and avoid the risk of migration.
Yeah, we tend to use a step-up approach where we would place the stent and then wait, because if the patient recovers, I think it allows you to wait until there's a clinical need to do an additional procedure. However, if there is more than 50% necrosis, that would inevitably happen. And under those circumstances, we would plan following waiting of about a week for the fluid collection to drain, for a fluid part of the collection to drain, we would schedule a second endoscopic intervention with the aim of doing a necrosectomy. So I think we can agree that there is still a lot to do, assessing the degree of necrosis, dedicated tools, and to decide if the first intervention is going to be the most important intervention, or if we need to schedule multiple interventions in these patients.
And do you leave a stent at the end if you have placed a lens? Do you place a double pigtail stent at the end of your procedure?
Yes, I think one of the most important takeaway messages from the recent paper regarding the complication rate of LUMS was that you either have to remove these stents very early by not later than 3 weeks, or alternatively, you can get away by placing a plastic double pigtail stent that will prevent the metal stent coming into contact with a fragile wall and causing bleeding. So I think that is my take-home message. We would either remove it if the follow-up imaging shows that the collection has been cleared, or we would leave the plastic stent, double pigtail stent in the lumen-opposing stent for longer if there's still debris, or in the third instance decide to do a necrosectomy if the two first instances have failed.
Okay, so we move to biliary drainage. So the question is, will US replace ERCP for malignant unresectable biliary strictures? These are the three papers, the three randomized papers published up to now. So the first two are one Korean and one is Bang, so it's the Orlando group. The patient, the numbers of patients is small, so there are 30 and 67 patients. They used biliary stents, so a narrow stents and viable stents, and they found no difference in any of the outcomes measures. Then there is another Korean stent, another Korean study, 125 patients, 61 by ERCP, 64 years underwent US, and the stents they used was a stent done for specifically for biliary drainage. So it's a stent mounted on a stent introducer with a SEMS that is that has a 15 millimeter uncovered portion inside the duct and a 85 millimeter cover portion, and it ends with a sort of with a hands that is similar to the lamps, so to avoid the migration of the stent. They had 155 days of follow-up. They performed 32 drainage from the bile duct, so choledochoduodenostomy, and 32 hepaticogastrostomy, and they found no difference in terms of technical and clinical success, but there was a significant difference in rate of complications, so 19.7 versus 6.3. The 6 months stent patency was much better, 85.1 versus 89 for the US drainage, and the need for intervention was actually significantly better for the US approach. There are some criticism to this paper because, for example, in terms of adverse events, there were a high rate of pancreatitis that is unusual for this kind of patients. So for patients with distal or with pancreatic cancer or with biliary cancer. So there's some criticism, but this is a kind of tells you that there might be some advantages. So can you talk about a little bit about the technique of performing biliary drainage? So we'll start with the choledochoduodenostomy, with a picture.
Yes, I think that this is very important, Alberto, because I think that we have to define the terminology before we can really start to talk about the management using EOS guided approaches. And I think on the left-hand side of the screen is the procedure that is performed using EOS, but in a retrograde fashion, identifying the common bile duct, and by placing a lumen-opposing stent connecting the dilated bile duct to the small bowel, to the duodenum, and that is what we call a choledochoduodenostomy. On the right-hand side, there are two approaches possible. The first approach is when we find a dilated segment 2 or 3 duct from the proximal stomach, and a stent is placed between a dilated duct in the stomach, known as an hepaticogastrostomy. But then there's also a very important third technique, which I think has been sort of neglected in the discussions, and that is when we use access from the proximal stomach, but then advance a guide wire across the malignant stenosis, across the papilla into the small bowel. And that is what we will refer to as a transgastric antegrade transpapillary procedure. And I think that in most of the studies, only hepaticogastrostomy or choledochoduodenostomy have been looked at, whereas the antegrade approach, I think, is a very important additional approach, because under those circumstances, of performing a choledochoduodenostomy or hepaticogastrostomy, you must create a fistulous tract, whereas you can avoid that completely if you perform an antegrade stent placement across the malignant stricture, and in so doing, you avoid the risks associated with placement and performing of creating of a fistulous tract. So I think that is the first thing that we have to agree, that there are differences in these techniques. If you ever look at the randomized studies, they have been done in order to look at the value of avoiding an ERCP, and that is what you've just shown. So can we, for distal malignant obstruction, avoid ERCP altogether? And I think there is some evidence suggesting that EOS may certainly be of considerable benefit to patients. However, I think we still await some more. We still need to have some more data to confirm this. And I'm particularly concerned about the risk of, with choledochoduodenostomy, the risk of cholangitis in these patients. However, the studies up till now have not shown that to be a major problem. But what are your thoughts on this?
The choledochoduodenostomy is easy. So it's much easier. So if you have distal biliary obstruction, to me, the choledochoduodenostomy, like this one I'm showing you now, it's a very easy procedure. So this is a dilated bile duct. You enter with a access stent, no exchange of anything. Open the stents. Usual procedure with the access stent. So then you release the stent under ultrasound guidance, so you don't need to detach from the wall, etc., etc. And this is a 3 minutes procedure.
Yes, absolutely.
So I think if the bile duct is dilated at least up to 12 millimeter, this is a kind of safe procedure. If you go to a bile duct that is smaller, this can be a little bit more tricky.
Yes. And do you have a preference for what size stent do you
I use
place?
the smaller one, 6 by 8.
Those, the 6 millimeter. I agree with you. I think if you're going to go that route, a smaller stent makes sense. Would you also place a double pigtail through the lumen, or
No.
don't you think it's necessary? Okay.
No.
Good. If we can move on to this technique is the antegrade technique. This is where we, from the proximal stomach, you can see the needle entering into the dilated bile duct in segment 3. And we can then inject contrast to define the anatomy. We can then advance the wire across the malignant stenosis, past the papilla into the small bowel. Once this is achieved, I think we have such a stable position that we can perform the endoscopic procedures that we need to perform, such as balloon dilation in an antegrade fashion. And finally, as shown there, we will deploy a stent in an antegrade way. I think the value of doing this is that because you don't create a fistulous tract, so that's one advantage, but also should there be stent dysfunction later on, you can always come back and do a hepatogastrostomy if your patient is still fit enough for further endoscopic work. So I think that there is, in my opinion, more than one solution to this problem.
So we move to the gallbladder. So with a video. So this is usual hot axios. I think the lamps with the catheter with the cystotome on the tip has really changed the way of doing procedure for US under US. So this is a gallbladder. The drainage is done, and then what you can do also intervention, similarly to what has been shown for the pseudocyst. So you can dilate. In this case, the patient had small stones, so it was just needed to perform a dilation and clean the gallbladder with the saline to obtain the stones to be removed. But you can also go inside if you have bigger stones, such as stones of 1 centimeter, 2 centimeter. You can go inside and perform lithotripsy. You can do holmium lithotripsy or a mechanical lithotripsy.
I know that this technique is very close to your heart, Alberto. Can you tell me, based on the recent study published in Gut by Anthony Theo, I think it has shown quite excellent outcomes. But what was very apparent to me is that they chose the size of the stents based on the size of the biggest stone in the gallbladder. Can you comment on that? How do you perform your technique?
So this is the results of the study that shows that basically the primary aim was the 1 year adverse events rate, and gallbladder drainage performed under US significantly reduced the 1 year, the 30 days adverse events, the reintervention, the readmission, and the recurrence of acute cholecystitis. No change in mortality. I agree with you about the stent sites. I think when you perform gallbladder drainage and you have stones, you have to place at least a 10 millimeter, a 10 by 10 millimeter stents that allows you to go inside. Sometimes this can be difficult in the duodenum, deep in the duodenum, when the gallbladder is approachable so only from the deep duodenum. And I think in this case, to have a 4 millimeter working channel can be a plus, because the catheter of the hot axios is 10.5 French, so it's a pretty big device for a channel of the echo endoscope. Or if you can also use a 15 millimeter if the gallbladder is really big.
You make it sound so easy, Alberto. How do you go back into the gallbladder? Do you use spyglass, or do you use a forward viewing normal endoscope? What do you use?
I just go with normal endoscope. so what I do is I usually follow the Hong Kong protocol. That is, you leave the stent for 15 days, then you go back and you start cleaning the stones until it's clean completely. When it's clean completely, you take out the stents and try to place a 7 French double-picted stents. In terms of cleaning, in terms of big stones, you can do, so the first case I reported, I used the Holmium laser through the spyglass, but it was just a waste of money, because you can just go through, you can just place through a ERCP catheter, so you don't need all this technology, because you have the view of the endoscope that basically helps you to see the stones, and then when they are broken, you use a basket or a retrieval basket for polyps to clean up the stones broken.
Fantastic.
And what is important to say, I think, for so if you try to do a definitive treatment, the one thing that is good is to try to approach the gallbladder from the duodenum, because then there's going to be bile coming out. So if you put in the duodenum, this is the normal natural way where the bile goes. While if you do as a bridge to surgery, or you will not leave the stents, you can use the transgastric approach when you can. So if it's not possible, you use the approach that is better in terms of view.
Absolutely, I agree. I think this has been very informative, Alberto. So everyone, I just want to thank my co-host this evening, Alberto Larghi from Rome, from Italy, for his insightful comments. And if there are no more questions, I would also like to thank the rest of the panel for these very interesting discussions that we had. And hopefully we can see one another soon when the Corona times have passed. Goodbye.
Goodbye.
So this was really an exciting meeting. Thank you, everybody. And as you said, Corona has made some changes, but I think even digitally, you looked perfect, and there was a very interesting topics. We started with Pentax technology, which is called Discovery, and this is a technology to have polyp detection. It's not about replacing the endoscopist, it's about assisting the endoscopist. And Timo and Peter have shown that the adenoma detection rate can really be increased. Then we have spoken about new devices. There's the Splash M knife, we have the key snare, or the bipolar coagulation. These are new tools which really help to improve EMR and ESD, and we have learned that even the submucosal layer is not the end. We can even cut the circular muscle layer to have a complete resection of early cancers. This is a very new thing, and I think this will lead to a lot of scientific discussions. And then we've learned at the end that there's a new linear scope with perfect visibility and maneuverability, all the new Pentax technologies which were presented. And there we have learned how good you can do drainage. If it's a pseudocyst, whether it's a fluid collections, you go into the biliary tree or into the gallbladder. Endoscopy is really an exciting field. Thank you everybody for joining in to this symposium, and thank you again, you are excellent speakers here. Bye-bye.